Sorry, this is just a short reminder about the elbow stability. I will start again about how important the posterior or the ulnar bundle of the lateral collateral ligament and the anterior bundle of the medial collateral ligaments are, because together with the ulnohumeral articulation, they are primary elbow stabilizers, the most important elbow stabilizers. We can roughly imagine that the ulna hangs on these two ligaments from the humerus, and the lateral ligament, lateral collateral ligament, and the anterior bundle of the medial collateral ligaments are, because together with the ulnohumeral articulation, they are primary elbow stabilizers, the most important elbow stabilizers. We can roughly imagine that the ulna hangs on these two ligaments from the humerus, and the lateral ligament also supports the whole radial head from the lateral side and from the posterior side. This is, let's say, most frequently described or used proposed mechanism of the injury: falling on the outstretched hand with fixed forearm. There is a strong valgus force applied and the axial compression, and we can see that actually the whole humerus or the whole body pivots around the medial side of the elbow. This causes the lateral structures to fail first, then the injury propels across the joint to the medial side, which can sometimes even be spared or not injured. This produces a wide variety of injuries, from simple elbow dislocations to the most difficult ones like terrible triad, which also includes the radial head fractures, the coronoid fracture. Most of the simple elbow dislocations can be treated conservatively. We can see that the all three columns of bony stability, they maintain the joint congruency, and this is the fundament of for the good ligament healing. On the other side, we see that in terrible triad injuries, there are two supportive columns missing. So we need to repair them to make this elbow stable again. If we don't make them, if we don't reconstruct them, this might lead to recurrent elbow dislocation or to chronic instabilities. Here we have a case of a young sporty guy who fell with his mountain bike in the mountain bike park. This is the radiograph of his injury. They tried to reduce it in the emergency department. They weren't successful, so they sent it to the hospital. We made a CT scan, and we can see that here are some fracture fragments caught in the ulnohumeral joint, that we have a type 1 coronoid fracture, and that the radial head doesn't have a fracture. So this is not a true terrible triad injury pattern, but we can call it a more complex elbow dislocation. So I like to approach these injuries from two different approaches, starting on the lateral side and going from the inside to the outside. First reattaching the anterior structures, and then moving on to the lateral side, testing the elbow. If the elbow is still unstable, then proceed with the medial approach. Of course, if we know that we are going to repair both sides, we can approach these injuries also from the posterior approach, more extensive. Just like some clinical examples, usually in these high energy injuries, we find disrupted or torn muscles on the lateral and on the medial side. And usually all ligaments or soft tissue structures are just pulled from the bony surface. So what we encounter is the bare bony surface, especially on the lateral side. That is true. I prefer transosseous sutures and suture anchors for the repair of acute injuries. There is a good healing potential for ligaments to heal On the contrast, for the more chronic injuries or instabilities, when we need the tendon grafts or internal bracing augmentation to repair this kind of injuries. Of course, we should not forget about the hinged external fixator. It can get us out of a lot of troubles, although it's not really popular anymore. A sequence of ligament fixation, transosseous sutures for the type 1 coronoid fractures. I drill the bone tunnels, and I always grab PASAM sutures also from the anterior capsule. Of course, the bigger fracture fragments should be fixed with screws or even special plates. Then moving to the lateral side, how to prepare the ligament. Before reattaching it, I think it's good to whip stitch in any kind the ligaments or even the muscles, because this can really provide a good tension force can be applied when reattaching the ligaments. Otherwise, if you just pass one suture through it, the suture easily cuts through the ligament. The lateral collateral ligament should be fixed in the isometric point. There is still, let's say, a lot of biomechanical discussion going on where this isometric point really is. But usually we have some soft tissue remnants, like seen here in this photograph, and this is a good anatomical guideline where to put our suture anchors or bow tunnel or whatever mean of fixation. I like to put the elbow in the upright position, so the hand faces upwards when I tighten, when I tension or fix these structures, because there should be no varus tension. Otherwise, the ligaments will be fixed in the legs position. I like to make this lateral fixation really strong, so I fix a lot, as many structures as possible. The whole posterolateral capsular ligamentous complex and also muscles should be repaired. If the elbow is still unstable, then we can proceed to the medial side. We can prepare the medial collateral ligament in the same manner as lateral ligament. These are the final radiographs of our sporty guy. You can see a lot of anchors were used for the reattachment of the ligaments and also the avulsed or torn muscles. Because this fixation is really strong, we can proceed with rehabilitation immediately. He started on the second postoperative day with active and assisted active range of movement exercises. These are his radiographs. After 6 months, we can see that there is no signs. There are no signs of elbow instability, and he returns to all previous activities. In more chronic injuries or chronic instability, for late reconstruction, tendon grafts should be used. Bone tunnels are drilled. They all mimic the natural course of the ligaments. There are a lot of docking techniques described. But in recent years, this internal bracing method, which actually is a ligament or tendon graft augmentation, emerged or gained real popularity. There are a lot of biomechanical laboratory studies which show that this kind of repair is much stronger than a standard tendon graft only repair, and almost as strong as a native ligament. So this is surely the future of ligament refixation, of ligament repair. There are some other hinge devices also available, mainly used for the protection of the acute repair. Just my thoughts about the different fixation techniques. I like transosseous sutures very much because they provide large footprint, but they are quite time consuming to make. Sutures anchors on the other side save you a lot of time. They provide a really strong fixation, but the downside I find is that they really fix everything to one small single point. Internal bracing, as I told you, looks really promising, especially for the athletes, because it allows early return to sport activities. Short summary: if we have fractures, they should be restored because only this provides a strong foundation for ligament healing. Ligament repair should be done in a, let's say, reverse order, as the injury starting on the anterior side, moving onto the lateral side, and only then, if still necessary, repairing the medial side. There are numerous techniques. I think they are all still valid, every with each good sides and maybe some downsides. Thank you very much.
Distal humerus fractures are quite common too, up to 6% of all fractures, incidence of 5 on 100,000 inhabitants. And there are two peaks, of course. One in the first decade. These are the fractures, distal humerus fractures in the young, in the child. The classic one you can usually treat with a closed or minimal invasive reduction and then K-wire fixation. And the other peak is in the 5th decade. This is the adult, either high energy or then later on low energy trauma. More female than male for all traffic accidents. This is what I said already. Be aware of the anatomy of the distal humerus. You will always see this kind of triangle, and of course the orientation of the condylar area with respect to the humeral shaft. This is what we want to reconstruct once we want to reconstruct a distal humerus fracture. Of course, we do have different classifications to know what we are talking about. The most common one still AO classification, differentiating extra-articular, partially articular, and completely articular fractures. Of course, we have other classifications like from Brian Murray or McKee and Doubly, so especially for the sagittal plane, sometimes very helpful. Once we talk about these fractures, we see mainly A-type fractures, 38%, as you can see here, so more or less extra-articular fractures, or articular fractures, C1 to C3, getting more and more complex, so with comminution, extra-articular as well as comminution, intra-articular in the C3 type, where we need to adjust our operative technique. Diagnostics, what do we need? Of course, conventional X-rays in two planes. In most cases, especially once we talk about B or C type fractures, of course, we use the CT, and in these cases, 3D reconstruction, as we could see in the talk before already, can be very helpful to plan the operative procedure. Of course, we have to go in with a clinical view as well to exclude additional injuries like vascular or nerve injuries, or have a look for Essex Lopresti lesion, especially in these unstable elbows, sometimes even combined with these distal humerus fractures. So this is what I cited before already. We could see good results after open reduction and angular stable internal fixation for these distal humerus fractures. Average follow-up here, it's rather short with just a year, but no secondary loss of reduction, which sometimes is a problem. One delayed healing of the osteotomy, or another paper out of these days, fractures of the distal humerus, early experience with these novel perpendicular plate, 46 patients, one delayed union, one implant failure. So very promising data with these angular stable and partially anatomically pre-shaped plates. So the solution, the question, of course, is if this is the solution for our problems, is this an easier fracture treatment, and can I avoid implant failure by using these implants, or these plates? Just the case, 61-year-old gentleman, you see this extra-articular A2 type fracture, treated with two plates, one on the lateral side, one on the medial side, and of course you might be skeptic, but this is what you get. After about 6 months, non-union screw breakage, because there was not enough anchorage on the shaft area and as well on the condylar area, and missing compression onto the fracture. So the fracture cannot heal because of missing stability, and the plate itself is not the winner. So revision with interfragmentary compression, you see this conventional screw and then longer plates bridging this area, giving more stability, additional bone graft, and then you get the healing. So don't forget about this interfragmentary compression, especially for the metaphyseal area. Stay to the principles. Anatomic reconstruction for the joint, stable bridging of the metaphysis to the shaft, respect the individual fracture morphology, respect soft tissues, and prefer angular stable plates, yes, but you may also use conventional screws or plates to come up with a good result. A2 injury, quite similar to the one before, as you can see here. These are not the newer plates, but this is just to show you it's about the principle, interfragmentary compression with this screw, and then additional plates to get kind of a neutralization with very good compression on the fracture. So stay to the principles. If I can go on. B-type injuries, mainly on the radial side, as you can see here, the radial epicondylus, more or less complex sometimes, and it's usually screws are enough. Sometimes you may use an additional plate to increase stability. Just a case, 30-year-old one, male. You can see the fracture here. Reduce it anatomically with 3 screws, and then you can augment it with a small plate here on the radial side. But this is sometimes necessary, but not always. Main part are the screws. Now to the C-type injuries, the more complex fractures of the distal humerus. In these cases, anatomically pre-contour plates can be very helpful and facilitate reduction as kind of a template. And usually you start with a less complex fracture to build up a stable column and then reconstruct the other after you have reconstructed the joint area, in most of the cases with an olectron and osteotomy, to improve the visibility of the joint area, and this way ease a bit the reduction. Be aware of this triangle and use plates in different lengths to avoid any stress riser in this area. So 41-year-old female, you can see the major displacement in the whole condyle area here, this displaced situation out of the joint, as you can see in the CT. After olectron and osteotomy, of course, you have to identify the ulnar nerve at the beginning of the surgery, and to really avoid any injury to it during the surgery. You can see the different pieces. Start with the so-called easier side to fix a stable column, and then you can reattach the other column to the already existing more or less stable column, temporary fixation with K-wires, and later on come up with these anatomically pre-shaped plates. If the bone fits to the plate, you can nearly be sure that reconstruction is absolute correct, and sometimes you may need some bone grafting to fill these gaps, as you can see here. Later here you can see the intra-op x-ray, and then you can see post-op. This free screw always for the joint to get some compression, and then the bridging of the metaphysis to the shaft. You may use sometimes the plate. It's a bit the safe method to avoid any problem with the osteotomy. But of course you can also do the sacral wiring. 51-year-old major displacement, as you can see here, usually primary treatment with the X-fix. And then you can treat it like this, different length of the plate, as I told you, interfragmentary compression of the joint area, and in this case, you have this sacral wiring for the osteotomy. 38-year-old male, I think last case of these C3 injuries, just to show you, you have this anatomically pre-contoured plate, and most of the times you start with a conventional screw for positioning of the plate, and then put in the angular stable screws, as you can see here. So you can combine the different screws, but think about it when to do. Here you see the final construct. Again, here the interfragmentary compression with a leg screw and then the long plates in this case. Angular stable plates, here even a third tubular plate with small screws can be helpful, but the plates itself cannot compensate for insufficient compression, insufficient reduction to come and overcome a fracture gap. So avoid fracture gaps, get clear compression, especially in the area, in the metaphyseal area, bridging to the shaft. So it's very useful, especially the anatomically pre-cured plates. So this is the main advantage, I think, of these plates. Of course, you need anatomic reconstruction of the joint. This is why you need this leg screw in the joint area, in the condylar area. Additional plate possible in B-type fractures. Yes, sometimes pre-contoured plates can facilitate reduction. And think about the conventional screws, use them first and then the angular stable ones. So it all, I think, sounds rather reasonable, but sometimes there is an extra case and you have this subtotal amputation in this young lady. You have a major soft tissue injury, of course, so you have just a small window to put in your fixation after the X-fix and after, of course, reconstruction here of the soft tissues, at least partly. Dr. Vascular surgeon, the plastic surgeon, this is all we could do through this small window to put in 2 plates. At least it holds for a few months at least. Then, of course, stability was later on not enough, so we had to change to a longer plate, as you can see here. This cannot be enough, so think about the long plates. This is just to show again, long plates in distal humerus fractures are the key to success, especially on the radial side. You can do it quite easily. And 2 plates, not only 1 plate in all these situations. So come to the end, stay to the principles. You need anatomic reduction of the joint, and angular stable implants are helpful, but are not the only key. Adequate reduction, combination with different screw types is fine. Think about it before, and the implant choice of when positioning is, of course, influenced by soft tissue and fracture morphology, so it's getting more and more individualized. With all these armamentarium, you can come up with a good result.
And these are the aims of the talk. And radial head fractures are also pretty frequent. It's a typical sport injury, and this is a typical injury mechanism where you can see that there is an axial force compression on the radius bone, and then you have the fracture, and here is the typical trauma mechanism we saw already in the talk of Tomo. You see here the axial compression, and then you have the pronation and the hypomocleon, and then you have the problem of your radial head fracture. And this is the dislocation problem too. So this is the posterolateral dislocation, and this will be more addressed by Morten later by his Monteggia and transolecranos fractures, but I would just want to show you how the typical mechanism is if you fall down and break your radial head. So it's the axial compression and the fracture, and if you go for diagnostics, the conventional X-ray is still the gold standard. If you have a clinical view, you look for swelling, of course, open fractures. It's important to document peripheral motoric and sensibility. And if you take an X-ray in 2 planes, watch this fat pad sign, which is always suspicious for a fracture. And I recommend liberally use of CT because it's sometimes really hard to identify fractures. Classification is Mason's classification. It's pretty old, but it's straightforward. It has a clear structure, therapeutic consequence. So 1 is not dislocated and it's conservative. 2 is 1 fragment and dislocated. It's surgical therapy. And 3 is multifragmentary comminution fracture. And here surgical therapy is recommended. And of course, the 4th was added later on by Hotchkiss with additional dislocation problem. So for Mason 1, think about the potential puncture. Here I show you the soft point where you can go in. So this is the radial head, this is the olecranon, and here it's not dangerous to go in to take away intra-articular blood. And this is for Mason 2 type fracture. If you have dislocation more than 2 millimeters and a surface problem more than 33%, then you will go for surgical therapy. And in this position, screws are very nice. Sometimes it's not stable enough and you need additional plates. So the surgical approach is the classical Cocker approach. So be aware of the deep branch of the radial nerve. So preparation is done in pronation. So you are sure that you don't have your radial nerve endangered. If you have a dislocation more than 2 millimeters and pain in supination and pronation, there is a significant better outcome after open reduction internal fixation, nicely demonstrated in these papers. If you have 3 or 4, then of course open reduction is the best way to go for. And here is the question, repair or go for primary prosthesis. And I will show you some newer data which shows that the primary resection is something where we are a little bit have been coming away from. So if the problem is substantial like this, then primary radial head prosthesis is a good idea. These are the anatomically pre-shaped low profile plates, and you see that this type of locking mechanism gives you a 30 degrees angle to put your screw into the perfect position. And if you want to use either a more proximal design, you can have this. And if you want to use a more buttress design, then you can use this. This is how it looks after postoperative repair. You see here the case, and you see here the position of the screws. And please be aware that it's important that your screws don't go intra-articularly. This study analyzes the plate distance, bone distance after plate adjustment, and it shows that those anatomically pre-shaped plates do have a very good anatomic fit, of course. So some other cases, this Mason type 3 patient, and you see here we use the buttress plate and primary reconstruction of the head using these screws. And this is after 6 months post-operatively, and this is the function, and as you can see, it's almost normal function. Another case, a female patient, 33-year-old, Mason type 4, which is a pretty bad problem for the blood supply. And in this situation, we also used such locking plates, as you can see here. And you can see here 5 months postoperatively the healing, and here important to keep free of the proximal radial ulnar joint. This is the function, and you can see it's almost normal. I want to draw your attention to this safe zone for these type of plates. This is very important. If you have your thumb up, then the safe zone is 45 degrees up and 45 degrees down to the lateral side. So in this position, if you put your plate on, you will not have a problem in supination or pronation. So Hotchkiss safe zone, this is something which is really good if you take it as a take-home message. It's very important to place your plate there. This paper demonstrates that these low-profile plates give a very good surgical result. So I strongly recommend that you use these plates. So now what about replacement? If you have a fracture like this, please do not go for on-table reconstruction, because this is something which not will work very good. So here is an example of a primary replacement. This is an older device. It's a dual mobility head. And you see here the position of the prosthesis towards the capitulum. There are even more modern designs. I will show you another one. This is a Monteggia-like lesion fracture, where we use the more modern design. And this is the intraoperative approach using a Boyd approach. So we started with a radial head, and after complete resection and debridement, we went for replacement. And you see here, you check the size of the radial head using those templates. And this is the implanting device for the shaft, and this is the shaft, which has a screw inside here, and which will expand inside of the shaft. So it will fix, and then, oh, sorry, you ream the shaft, and now it goes forward. And here you bring in your prosthesis using this bringing in device, and then please check the. Oh, can I go back somehow? Okay, because this is an important picture I want to draw your attention to. It's important that you check the position of the prosthesis. On the AP view, it's important that you don't have an overstuffing. You must check the prosthesis exactly in the position of the proximal ulna, and in the lateral, you have to adjust the prosthesis very correctly to the capitulum. So then we will go forward, and then after this, we put a plate on the olecranon, and this is just to demonstrate you how you can do this using a Boyd approach. It's a little bit slower. Okay, this is postoperative X-ray. Again, you see here, no overstuffing and perfect adjustment to the capitulum. And this is 3 months later, a stable joint after healing. Those modern prosthesis designs using pyocarbon heads do have a very well distribution of contact pressure, which was demonstrated in this paper. So it is good to use those modern plates because they reduce the pressure for the capitulum. And these review papers demonstrate the therapeutic approach. So if you have a radial head fracture, Mason 1 is conservative, Mason 2 use low profile implants, and 3 open reduction if possible, and if not, then go for prosthesis. Simple resection is not recommended anymore, and this is the latest news. This review studied 21 studies, more than 400 patients, was published 2 years ago, and what they found is also the same. I will show you. So the stability of the joint is critical. Mason 1 conservative, 2, and you have a gap, repair using screws and plate. If you have Mason 3, reconstruction is possible, plates. If not, replacement using one of those modern prostheses. And check for additional injuries, as Tomo demonstrated you nicely before. So thank you very much, and I'm very happy to answer your questions in the Q&A part now. And now it's my pleasure to announce Morten Schultz Larsen from Denmark, and he will talk about dislocation fractures, Monteggia-like lesions.
These are my disclosures, none for this talk. And like Peter said, I will talk about dislocation fractures, the Monteggia and the transolecranos fractures. So I'll jump right into the case. This is a case we had about a couple of years ago. It was a low energy fracture. Doesn't say on the slide, but it's about 45-year-old male brought into another hospital where they temporarily X-fixed, put a K-wire in the olecranon, and then sent him to us the same day. And we received him, and on the next day, this was our solution. So this is what you can get out of it, and I will now go through our philosophy of treating these fractures. It's very important that you have good X-ray and CT scans and analyzing the fracture, both for the bony stability, for the classification of the fracture, and also for the ligamentous stability, so well explained by Dr. Tomo Havlicek. Then we sit down and think about making a preoperative plan, and perhaps a plan B if things doesn't go the way we want them to. The surgical approach is important. and for us it's very crucial to see what we're doing and to reconstruct anatomically. So we often need to cut even intact ligaments. You can always reattach ligaments, like Dr. Tomahavicek explained. So if it's necessary to see what you're doing, then you have to cut these ligaments. Then we analyze each fracture, each fragment, in telling us where to go and what to do. Is the radial head reconstructible or is it not? Do we need a prosthesis? What kind of implants do we need? There's a lot of implants available for these type of fractures. And then we have to decide in the aftercare as well. So to go a little bit more in detail about what our thoughts are on these issues. For the Monteggia fractures, we look to the olecranon, the proximal ulna, for the fracture there, analyze the fracture. Is it a simple fracture, which is almost never is, or is it a complex fracture, a segmental fracture, which is very often is? How is the fracture in the coronoid process, and how is the fracture of the radial head? The idea, the whole goal of this is to reconstruct the joint congruency, especially the ulnar humeral congruency between the ulnar condyle, the coronoid, and the olecranon. That is the key point that we want to reconstruct. We can use the well-known classifications. The Monteggia fractures are well classified by the Beto classification for the type 1, 2, 3, and 4. And the type 2, Beto type 2 can be underclassified in the Jupiter classification A, B, C, and D. I'll show you a couple of examples for that, but I think all of you may know these classifications. So why is that important? We know from literature that the Beto type 2 is the one associated with the poor outcome. Even more so if it's combined with the A and the D Jupiter types, if they have a radial head fracture or if they need a reoperation. So get it right the first time, guys. The coronoid fractures, as explained before, you can use the O'Driscoll classification, or you can use the more simple and older Regan-Murray. I think for most cases in these Monteggia-like fractures, the Regan-Murray classification is sufficient and serves us well, and is helpful in helping us decide what to do about it. The radial head fractures was excellently told about by Peter, so I won't use a lot of talk on that. I completely agree with his ideas about how to deal with this. If you can fix it, you do so. If you can't, then you replace it. And for the ligamentous stability, this is a whole chapter, but I won't go into that. I will just say in this talk that it's as important as the bony stability, but I won't talk more about it. Dr. Tomahavicek has done that very excellently as well. Now to our working horse here is this is the posterior approach. This is the working horse. We use the lateral decubitus, and we expose the proximal ulna and the fracture, and we almost always take off the anconeus to gain access to the radial ulnar joint. Now, from there on, it's a bit different and depending on the fracture, but I like to put on the plate at this point, not the entire plate, but to put on a plate to so that I can reconstruct the length and the axis of the proximal ulna I only use 1 or 2 screws proximal and 1 or 2 screws distally, just for provisional stabilization of the ulna, to give me an idea on how I can reconstruct the rest of the fracture. Now, it's almost always a bridge plate, but if it is a simple fracture, then you need interfragmentary compression. But usually you can use it as a bridge plate. If you need to put screws outside the plate, that's quite all right. If you have larger fragment that you need to reconstruct, that's okay. And you can even, at this point, even if you haven't looked into the radial ulnar joint yet, if the coronoid fragment is very big, you can probably provisionally reduce it at this point. But otherwise, you should leave some screw holes in the plate for later fixation of the coronoid. Now you can cut the annular ligament, take it off at the ulna, or cut it as you want, if it's not torn. And then you can look at the radial head, and at this time, you can make the final decision about reconstructing or replacing. If you must replace it, then you can remove the head now. This gives you an excellent view of the anterior side of the coronoid and the anterior capsule, and you can do all your reconstruction with a very good view. If the radial head is intact, or if you reconstruct the radial head, then you often have to take off the lateral collateral ligament complex from the lateral condyle. And when you do this, you can open the anterior part and see the coronoid quite good, almost as good as if the radial head was gone. So at this point, it's a good idea to fix and reattach the coronoid. There are different techniques about that. You can use the loop suture, which is very convenient and also gives you the opportunity to put sutures in the anterior capsule, which can be very helpful for stabilization of the anterior stabilization of the elbow joint. For larger fragment, use a lag screw, or use a plate, or use any kind of combination. Often in these Monteggia-like fractures, or Monteggia fractures, you have you can have double coronoid fractures, a large fragment and a smaller fragment. So often you need a combination of these techniques. And the radial head fracture, as I said, if possible, reconstruct it. I find it often in these cases that it's a Mason 3 kind of fractures that doesn't allow reconstruction, but if it's possible and if you are able to do it, you can do so. And replace it if you can't. Or like Peter said, I think maybe we have forgotten a little bit about removing it or resecting it and leaving it. But you have to be sure about the stability, that even though the radial head is a secondary stabilizer, it's still important to get enough stability to allow early motion in these elbows, or they will be very stiff. So back to our case. So what do we have here? We have a beta type 1 with, as you can see already here, an intact radial head, which is quite uncommon, but nevertheless so. We also have, like you see here, the radial head intact. We have a large coronoid fragment, and we have a bad segmentary ulnar fracture. So to walk you through what we did, again, the posterior approach, or the Boyd approach, as someone calls it. We started up by reconstructing, putting 1 or 2 screws up in the olecranon and 1 screw down here, just to gain length. And then we could reattach. We took the anconeas off. We could see the large coronoid fragment here, and we could actually reduce it anatomically, almost anatomically, see a little displacement down here, but I think maybe that's because the olecranon and the distal part is not quite anatomically reduced, because the joint is very nice. So we could fix that with screws from the radial side, one screw up here. Then, to be sure that we had the reconstruction correct, we took off the lateral collateral ligament complex here, so that we can see the joint, we can see the anatomic reconstruction, put in this lag screw, and then refix the annular ligament and reattach the lateral collateral ligament complex and immobilize him for 2 weeks, and then allow for active mobilization. So this is how our concept is for these kind of fractures. I have another case for you. One of the bad ones, the combination of a beta 2 and Jupiter D, which has the poorest outcome. In this case, the radial head was not reconstructible. You can see half of it here, and the other half is in bits and pieces down here. We have, like I said, that we often have a double coronoid fracture, or even a triple, if you could say so. You can see there's a tip up here, there's a larger fragment here, and there's even a part of the coronoid or the proximal ulna over here. So again, the posterior approach, incising the annular ligament, and then again aligning the ulna, the proximal part and distal part, and putting on the plate provisionally with a few screws. And we were able to reduce first the larger coronoid fragment and reattach that with a screw. Then we, after removing the radial head, we could see in the joint, and we could see that the tip, this little part here, was still loose. So we could catch that with a loop suture through the plate and reattach it on the back of the ulna, and then putting in a perhaps a little bit too large radial head prosthesis and refix the annular ligament. In this case, it wasn't necessary to take off the lateral collateral ligament complex, so no need to reattach that. In this case, I have a video. It's not perfect movement, but it's still for this complex fracture, I think quite satisfactory what you can get with this complex fracture. So to summarize, do yourself a favor and analyze those X-rays and CT scans. You can prepare very well for what you meet when you go into surgery. Think about the bone stabilization. Think about the classification and the ligamental stability, and then make your plan. For the surgical approach, I think maybe other approaches can work for some, but the posterior approach or the Boyd approach is, for me, almost always good. If you need to cut intact ligaments, it's okay. Just refix them with the way that Dr. Tomahovicek told us, and then pick your implants and prosthesis after well-prepared thought, and make them move as soon as possible after surgery to get good results.